Good morning everyone. My topic is about pulmonary tuberculosis. So it is a contagious bacterial infection caused by Mycobacterium tuberculosis, primarily affecting the lungs. It spreads through the air when an infected person coughs, sneezes or talks, releasing tiny droplets containing the bacteria. So next is the prevalence. So pulmonary tuberculosis remains a major global health issue with about 10.6 million cases reported in 2022. So pulmonary tuberculosis accounts for around 85 to 90% of these cases. It caused 1.6 million deaths in 2021. The disease is most prevalent in low and middle income countries, with India, China, and Indonesia being the hardest hit. These nations are part of the 30 high burden countries which contribute to about 87% of global tuberculosis cases. So next is, there are three stages of pulmonary tuberculosis. So first is exposure. So it happens when an infected person has been in contact with or exposed to another person who has tuberculosis. So the exposed person will have a negative skin test, a normal chest x-ray, and no signs or symptoms of the disease. Next is we have the latent tuberculosis infections. So this happens when a person has TB bacteria in their body but no symptoms of the disease. The infected person's immune system walls off the TB organisms, and the TB stays inactive throughout life in most people who are infected. This person would have a positive skin or blood test for TB but a normal chest x-ray or one that only shows past scarring from the disease. They would have no signs of active infection in other parts of the body. Next is we have the active disease. So this person has signs and symptoms of an active tuberculosis infection. The person could have a positive or negative skin test or blood test for TB and a positive chest x-ray, biopsy or other finding shows an active infection. So next is we have the pathophysiology of tuberculosis. So tuberculosis begins with the inhalation of airborne droplets that contains the Mycobacterium tuberculosis. So these droplets are expelled into the air when an infected individual coughs, sneezes, or speaks. So once inhaled, the droplets travel through the trachea and bronchi, eventually reaching the alveoli in the lungs. So the alveoli are the tiny air sacs where gas exchange occurs, making them a prime target for the bacteria to establish infection. So next, the bacteria settles in the upper lobes of the lungs or the apices, where they begin to multiply. So this region is ideal for the Mycobacterium tuberculosis due to its relatively high oxygen concentration, which the bacteria thrives on. So next, after colonizing the lungs, the Mycobacterium tuberculosis can spread through the lymphatic system and bloodstream to other parts of the body, so including the lymph nodes, the liver, kidneys, and bones. So the systemic can lead to extrapulmonary tuberculosis, such as tuberculosis meningitis, renal and orogenital tuberculosis, bone and joint tuberculosis, tuberculosis enteritis, miliary tuberculosis, and tuberculosis pleural effusion. So next, the presence of the bacteria triggers an inflammatory response in the lung tissue. So immune cells such as macrophages, neutrophils are recruited to the site of infection. The inflammation aims to isolate and eliminate the bacteria but also lead to tissue damage. So next, macrophages play a critical role in attempting to engulf and digest the tuberculosis bacteria through a process called phagocytosis. Next, in response to the infection, the body activates specific T lymphocytes, a type of white blood cells that are tailored to recognize and respond to the tuberculosis bacteria. So these lymphocytes are crucial for initiating the immune response and coordinating further attacks against the bacteria. So the activated T lymphocytes produces enzyme known as T lytic enzymes that can induce the death of infected macrophages and other cells harboring the TB bacteria. So this targeted destruction is an essential part of the immune response but also contributes to the local tissue damage. Next, the action of these enzymes can lead to the lysis or breaking down of both the TB bacteria and the surrounding alveolar alveolar tissue. So this results in necrosis of the lungs, contributing to the clinical manifestation of tuberculosis. Next is, as the inflammation and tissue damage occur, the lungs produce exudates, which are fluids, cellular debris that accumulate in the air spaces. So this fluid can consist of the dead bacteria, immune cells, and proteins, contributing to symptoms such as productive cough. So next, the accumulation of exudates can lead to partial blockage of the bronchi and alveoli, obstructing airflow. This obstruction can cause difficulty in breathing and reduce air exchange in an affected lung area. So as the bronchi and alveoli became obstructed, the normal diffusion of oxygen into the blood and the carbon dioxide out of the blood is impaired. So this disruption in gas exchange can lead to decreased oxygen level in the bloodstream. With certain regions of the lungs inadequately ventilated due to obstruction and inflammation, areas of the lungs may not receive enough oxygen, leading to a reduction in overall lung function and respiratory distress. The impaired gas exchange ultimately results in a lower oxygen carrying capacity of the blood. So this condition can manifest as fatigue, weakness, and dyspnea or shortness of breath as the body struggles to maintain adequate oxygen level. So prolonged low oxygen level in the tissue known as tissue hypoxemia can cause cellular injury and dysfunction. So hypoxemia can lead to systemic effects such as organs becomes starved for oxygen. So in response to reduced oxygen level, the body attempts to compensate by increasing the respiratory rate or tachypnea. So this rapid breathing is the body's way of trying to enhance oxygen intake and maintain homeostasis. So the immune response of the tuberculosis leads to the formation of granulomas, so organized cluster of macrophages that attempt to contain the bacteria. So this encapsulation is the main sign of tuberculosis and signifies an ongoing immune response. So the granulomas form a protective wall around the tuberculosis bacteria, attempting to prevent their spread to other areas of the lungs and the body. So this walling of the bacteria is a key feature in managing the infection. So over time, the granulomas may become fibrotic, leading to the formation of scar tissue and that replaces the normal lung architecture. So this fibrosis tissue can compromise the lung function. So next, the center of a granuloma may necrotize, leading to the formation of gone tubercle, so which is a characteristics of primary tuberculosis infection. So this lesion represents the localized area of infection. The necrotic tissue in the center of the gone tubercle may take a caseous or cheesy appearance due to tissue breakdown. So this caseous necrosis is a distinguishing feature of tuberculosis. As the granuloma heals, it may develop into a collagenous scar. So this scarring process can lead to permanent damage to the lung tissue and reduced respiratory function. After the initial infection, if the immune system is effective, the TB tuberculosis may enter a dormant state, remaining inactive within the granulomas. This dormancy can last for years without causing symptoms. If an individual's immune system becomes compromised due to the conditions like HIV, cancer, malnutrition, or other diseases, the dormant bacteria can reactivate, leading to active tuberculosis infection. So the reactivation of dormant bacteria results in active tuberculosis and more resistant type of TB. Characterized by a resurgence of symptoms, the bacteria can begin to multiply again, spreading within the lungs and potentially to other organs. So this is called the extrapulmonary tuberculosis. So it can lead to fever. So fever is a systematic response to infection and leads to increased energy expenditure as the body works to raise its temperature to help fight off the infection. So BMR, so during the infection like the TB, the body's immune response is activated, leading to increased metabolic demand. The immune system requires energy to produce antibodies, recruit immune cells, and carry out other functions essential for fighting the pathogens. So anorexia, so it refers to a decreased appetite or an aversion to food. So Cachexia is a complex syndrome characterized by severe weight loss, muscle wasting, and general decline in physical health that cannot be fully reversed by nutritional supplementation. So last is weight loss. So we come now to complications of tuberculosis. So the ongoing immune response can lead to increased production of lytic enzymes which can damage not only bacteria but also the host tissue. This can exaggerate the lungs injury and lead to other complications. So atelectasis refers to the collapse of the lung tissue due to obstruction or inflammation. In TB, atelectasis may occur in areas where the airways are obstructed by granulomas or exudates, leading to impaired lung function. So extensive damage to the lung tissue can lead to necrosis, where tissue dies due to lack of blood flow or infection. So scarring can form the infected areas, and cavitation or formation of air-filled spaces may occur, leading to more significant respiratory issues. The progressive and extended destruction of lungs tissue caused by active TB, so leading to severe respiratory impairment and in advanced cases, respiratory failure. So the gun tubercle may eventually ulcerate, leading to the release of infectious materials. So this process signifies an advanced stage of infection and can have significant clinical implication. So ulceration can damage blood vessels in the lungs, resulting in hemoptysis or coughing out blood. So these symptoms is a critical indicator of active TB and requires immediate medical attention. Ulceration may also lead to the expulsion of gaseous necrotic material into the trachea, resulting in a productive cough. The presence of necrotic material indicates the severity of the lung damage and the extent of infection. Over time, the gun tubercle may heal, forming a scar tissue. So while this may reduce symptoms, it can also lead to lasting impairment in lung function. So healed gun complex or granulomas may be visible as parenchymal lesions on chest X-rays. So these lesions are indicative of past TB infection and can serve as a marker in the assessment of lung health. So we come now to signs and symptoms. So first, coughing that lasts 3 or more weeks, chest pain or pain with breathing or coughing of blood, loss of appetite, fever, chills, night sweat, and fatigue. So next is we have the laboratory and diagnostic test. Sputum microscopy. So a sample of sputum is examined under a microscope after being stained to detect TB bacteria. So we also have sputum culture, so to grow and confirm the presence of Mycobacterium tuberculosis and detect drug-resistant strains. Chest X-ray, so show nodular lesions, patchy infiltrates, so mainly in the upper lobes or in the apices of the lungs, so cavity formation, scar tissue, and calcium deposits. So we also have tuberculin skin test or the Bantok test. So it involves injecting a small amount of purified protein derivative or PPD from the tuberculosis bacteria into the skin. So usually on the forearm. So exposed to the Mycobacterium tuberculosis. Next is we have nursing management for patients with tuberculosis. So first is infection control. So isolation. So place the patient in a negative pressure room to prevent airborne transmission. Follow airborne precaution. So N95 mask for healthcare workers, surgical mask for patients should be worn. So patient education. Teach the patient about covering their mouths when coughing, using tissues, and wearing a mask when outside the room. Next is we have promote medication adherence. So directly observe therapy. So monitor and ensure that the patient takes their medication as prescribed to prevent drug-resistant and treatment failure. Next is we have educate on treatment. So explain the importance of completing the full course of treatment, 6 to 9 months usually, and then discuss the potential side effects. Next, monitoring and assessment. So vital signs, regularly assess for fever, respiratory rate, and oxygen saturation. Respiratory status, so monitor for signs of dyspnea, chest pain, and worsening cough, and listen for lung sounds. Nutritional status, assess and manage weight loss and malnutrition, which are common in TB patients. Mental health support, provide emotional support and assess for anxiety or depression, as TB treatment is a long-term and can be isolating. Fourth is we have promote risk and activity. So encourage adequate rest during the acute phase of illness, but gradually introduce physical activity as the patient improves. Lastly, we have patient education. So lifestyle modification, instruct the patient to maintain a balanced diet, avoiding smoking and minimize alcohol use. Follow-up care, so explain the importance of regular follow-ups, visits, sputum tests, and monitoring for any side effects of medication. Next is we have medical management for patients with tuberculosis. So first is anti-tubercle drug regimen. So this is the first line treatment. So first is the intensive phase for the first 2 months. So first is isoniazid. So it is a bactericidal that kills actively dividing the bacteria. Rifampicin. So it is highly effective in reducing the bacterial load. Pyrazinamide. So it works well in acidic environment like those in inflamed lung tissues. Ethambutol, so it prevents the bacteria from becoming resistant to other drugs. Next is we have the continuation phase. So this is the next 4 to 7 months. So isoniazid and rifampicin are continued after the initial 2 months intensive phase. So the total duration of treatment is typically 6 months, but it may extend up to 9 months in certain cases. So next is we have treatment of multi-drug resistant TB. So this is the second line treatment. So fluoroquinolones, potent antibiotics that inhibit DNA replication in TB bacteria. So it is essential for MDR TB treatment. Injectable drugs such as amikacin, capreomycin, and kanamycin. So these are strong bactericidal agents that inhibit protein synthesis, crucial for treating MDR TB tuberculosis. So binaquilin, a newer drug that disrupts energy production in TB bacteria, is specifically approved for MDR TB drugs or multi-drug resistant tuberculosis. So delamanid, or another newer drug that inhibits mycolic acid synthesis, enhancing multi-drug resistant tuberculosis treatment regimens. So lisinosid, effective against TB. This is an antibiotic that inhibits the protein synthesis and is used for extensive drug-resistant TB, such as XDR-TB. So clofazimine, an antimicrobacterial used mainly for leprosy, it also binds to TB DNA, inhibiting replication. Next is surgical management for patients with tuberculosis. So pneumonectomy, which is removal of one entire lung, is reserved as the last resort in serious cases of tuberculosis which are drug resistant. So next is we have lobectomy, which is removal of lobes of the lungs, is a serious cases of multi-drug resistant tuberculosis if it has affected only a lobe or part of the lungs. So lastly, we have the prognosis. So the prognosis for pulmonary tuberculosis is generally favorable, with about 85% of patients with drug-sensitive TB cured within 6 to 9 months of appropriate treatment. So which typically involves a combination of the first line anti-tubercle drug like isoniazid and rifampicin. However, factors such as delayed diagnosis, the presence of drug-resistant strains, and underlying health conditions such as HIV, AIDS, and diabetes can significantly worsen outcomes. So, poor adherence to medication can lead to treatment failure and increased resistance. Therefore, early diagnosis, consistent medication adherence, and regular follow-up care are crucial for improving the prognosis and ensuring successful recovery. So that's all. Thank you.